Well, good afternoon. I know you have a lot of presentations today. I hope you find this one to be very exciting. My name again is Kiran Sahota. I have been, I retired from county employment 5 years ago after being there for over 25 years, both in protective services, law enforcement, CIT training, and I ended up retiring as a senior behavioral health manager. Also have worked for a decade under the old MHSA. I was a statewide coordinator, so very familiar with obviously with MHSA, the BHSA transformation, and Prop 1. So when I retired, the state called me and said, "Hey, Kiran, now that you're not working in a county, would you work on a project for the state working with all the counties?" And at that time, that was back in 2021, we were able to gather 7 counties on for phase one, and we now have 8 counties in phase two. And so we're going to go through the history of psychiatric advance directives. For some of you, you may have heard some of this as I have presented before. I do have new slides. There's always something exciting happening in the world of psychiatric advance directives. And so here we go. So, for those of you, I want to give you a little history about psychiatric advance directives. In 1967, the first medical advance directive was developed. In 1990, Patient Rights Act was finally put forward. And in 2023, we finally had an Assembly Bill 1029 that formally integrated any sort of mental health directive in an advanced healthcare directive and provided for a standalone PAD. Because as we know, there are folks that don't want the medical advance directive, and we'll go into why in just a second. And then, as we know, also in 2023, PADS, or psychiatric advance directives, which you'll hear me say PADS now, was implemented in statute under Care Court. And so when we look at advanced care planning, there are several aspects of advanced care planning. Most of us are familiar with the middle one, the medical healthcare directive. I have one, my husband has one. We look at those end of life and life-saving type of directives. If you look in probate under a medical advanced healthcare directive, it is very specific medical care with one little paragraph to talk about your mental health if that is something that you wanted to address. So psychiatric advance directives are in probate as a directive, and they specify preferences specifically for mental health and substance use care during a behavioral health crisis. And the wonderful thing about this aspect is that this is a document that can transition with an individual throughout their life. So think of a 19-year-old who's having their first psychosis, and think about how many different times they will change medication in the course of their life. Also, getting married, having children, still could have crisis throughout their lifespan. And so here is a document that literally changes and evolves with you as your life evolves. You then have your medical advance directive, which is not typically used through the lifespan. It's very specific. You have lost capacity, and it can only be used by a proxy doctors during lost capacity, mainly for the medical conditions. And then, of course, we have our pink form, or the POLST, the physician's order for life-sustaining treatment. And that really is those end-of-life decisions and the DNRs and your palliative care. So many of us don't even realize in California, we have 3 different types of directives that really can guide our care when we might not be able to voice that in that moment. So when we dig a little deeper into psychiatric advance directives, it is a patient rights document of self-determination intended to be completed before an emergency or before a crisis while an individual can still think clearly about their treatment and recovery journey. And the PAD will communicate their preferences under really key components. And we look at why. Why is that important? It's autonomy. Oftentimes research has already shown, if you look at SAMHSA's research on PADS specifically, and also Duke University, a lot of research on PADS, the responsibility when someone fills out a PAD it actually offers them more responsibility for their care and treatment. They are more likely to be medication compliant and seek care and assistance prior to the crisis hitting that pivotal arch. And it really helps with them in problem solving as well. We look at some of the key elements of a PAD, and it's how do I want to be supported in a crisis? And who would be my preferred contact? If I don't want to have a proxy, I don't want someone to make decisions for me, but I want someone to be there to advocate for me, who would that be? Here's my preference for medication. Here's what I have allergic reactions to. Um, I happen to have, I'm on the autism spectrum disorder and have a diagnosis. And so being able to put all of that information in your PAD. So what makes a PAD legal? Well, in California, under probate 4679 and 4701, we have two types of PADs in California. You can do one, you can do the other, or you can do both. We have an instructive PAD, and this project that I work on and work with the counties is the instructive PAD. We are not looking at a power of attorney. We are not looking for someone to take over during lost capacity. We are trying to address a crisis prior to lost capacity. What can we do in the moment of someone's crisis to help de-escalate that situation, return them to baseline, perhaps contact the preferred contact, help reduce the hospitalization and the incarcerations? And so really looking at that instructive PAD, what can I do for you in that moment? Or you could also have a proxy PAD, which includes that durable power of attorney and your specific, if I lose capacity, this person is in charge, and you don't have to have, at no time do you have to pick a proxy, but it also is very specific to lost capacity. So impacts on crisis care, and if you think about all that's happening in our state right now, back in 21-22, which is about the most current data we have on 5150s, we have about 102,000. These are 3-day psychiatric 5150 holds, not the application, but the actual 3-day hold. 82,000 of those reported were over the age of 18. When we look at what we want to accomplish with PADS, if an average stay for 3 days is about $10,000, almost $11,000 a stay, if we were to have just 1% utilize a PAD and not end up in hospitalization, 820 people in the entire state of California, we would save the state almost $9 million in hospital care. And we look at the services being cut right now due to the transition of funding. Just think of where else we can utilize this funding, especially for those services for individuals in their communities. So we also look at PADS within a crisis workflow. Why do we want to do that? What's important about that? It's enhanced care crisis response and care coordination. It's assisting an individual to reach their baseline more quickly, contacting a preferred contact, building trust with the individual, utilizing their voice and choice, and saying, hey, I see that you have a PAD. Can we look that up together? Safety planning. I had one of our peer support specialists say, this is like a walking safety plan, which is exactly true. It reduces unnecessary hospitalizations and incarcerations. It may increase voluntary hospitalizations. Someone that says, you know what, I know where I'm at right now, and I know what I need, and can also assist in individual and staff safety. So what's in the digital PAD? What's in the digital registry? So the activity started in 2021 when we had 7 counties come on board to build the platform, to look at PADS and how do we utilize them? Why are they not being utilized in California? The MHSOAC at that time provided a little seed funding to gather counties on board, and 7 counties came on board to build the digital registry, something that does not exist not only in California, but a interactive digital registry does not actually exist in any of our 50 states. So what we've created, which 7 counties have created, is truly innovative. And the other thing I like to say is that we utilized the MHSA funding and we utilized it and actually have a product. We created it together. It wasn't a bunch of one-offs, which sometimes technology can be. And if you look at AB 133, which is it's part of the EHR information exchange, they were supposed to create for $10 million a pulsed registry. And in 4 years, they haven't done that. So I'm pretty darn proud of our counties and our contractors in being able to actually accomplish this. So we actually looked at PADS from around the nation, and our peer support specialists and our peers and our work groups, we had over 120 different work groups in looking at what's the most important information that you want in it. Family members, what's the most important information they want in it? Law enforcement, what's the most important information you want to receive? And so we built truly what's an amazing product. And then phase two, which is what we've just entered now, is the rollout. So we built this digital registry and now we're testing it. Now we're rolling it out. Now we're actually going to train crisis teams, law enforcement, hospitals to ask, do you have a pad? And then how to utilize that. So when we look at some of the just user-friendly aspects of our pad, here's an example. Richard is our prime example. We want to, and our facilitators work with our individuals that are filling out the pad, and most individuals are putting a picture on because they want everyone to see this is who I am when I'm not in a crisis. I don't always look disheveled or angry or um, I normally wear glasses or, so they have a picture of themselves and they want everyone to say, look it, please humanize me in a crisis. And as you can see throughout the page, we have de-escalation. We have what Richard specifically says, I can be stressed by the presence of law enforcement. My primary language is Spanish. I like to talk about my daughters. I like to talk about baseball. So really giving some really great information for when law enforcement or crisis teams first come on the scene. Another fabulous aspect of it is it's so user-friendly, and they get to choose by consent who has access to their information. So law enforcement might be able to go out and say, hey, do you have a pad? And the person says yes, but law enforcement says, oh, I don't find it. Well, because the person didn't give them authority to access it. All of it is based on consent, which I love. And so the medical professionals, you can have them have all your information, first responders, and first responders are your AMR, your fire, your crisis teams, and then law enforcement is completely separate. Law enforcement also and our crisis teams really receive just a short, more of a brief, top, really highlighted information. Hospitals will receive more in-depth information. And does the pad have HIPAA information? It's one of the biggest questions. Actually, it doesn't. It is voluntary. All the information input into the pad is from the individual. It is voluntary. Also, it is not a medical document. And a lot of folks think, oh, it's a psychiatric advance directive. It's got treatment information. No, there is no treatment information. It is how the person would like to be treated. These are my preferences. But it is not a bidirectional. Your clinician, your doctor cannot put information into your pad. It is no different than the advanced healthcare directive you may have at home. That is your personal directive. It is a legal document. So it is protected on a HIPAA compliant platform, but it is not considered under the statute of HIPAA to be a HIPAA document. Some of our stakeholder quotes as we built the project is, as peers, we've really done a great job putting this together. I think we've had our voice in almost every step. We find that the PADS technology platform developed in phase one has increased individuals' knowledge, understanding, and acceptance of PADS. And we believe that phase one resulted in an increase in acceptance by and use of PADS by individuals that bodes well for the platform, being able to enhance the support and care provided to individuals in the participating counties, as well as the potential for replicability and scalability throughout California. One of our prime aspects of the replicability is we had 7 counties that started the project. We now have 8 counties with Alameda joining us. And so when we talk about replicability, it is so easy now as we are just simply rolling it out in doing our presentations, engaging our facilitators. We have an ongoing monthly facilitator group to really help our peer support specialists or whoever is facilitating. It is also a document that is so easy to use. You can actually sit in your living room and do it yourself if you didn't want someone to help you. And then also the access for our crisis teams will be very easy, and I'll show you that in just a second as well. So here's my one of my pet peeves right now in the state of California, I'm not going to lie, is why are we not talking more about pads? I hear about it at the state level. Everyone says, oh, we're talking about pads. Well, pads should be part of anything with justice involvement. Pads fit seamlessly through anything under Prop 1, most specifically, any of our early intervention and first psychosis episodes, as well as FSP. Excuse me, FSP. Oops, I coughed and I moved it. FSP is probably one of our most prevalent areas where we should be talking about FSPs. I mean, about pads, and in Care Court as well. Care Court is already a great platform for pads, and yet no one's filling them out. Why? Why are we not doing more for our individuals? So you can see it fits in. It fits in perfectly across the board. When we look at training, one of the other aspects I wanted to mention on the platform is it is translatable in anybody's language. So we have already identified in our 8 counties, we have 10 threshold languages, but we also will have it accessible when the state, ideally we want the state to take this on, right? And we would have it easily accessible in all languages. And also another thing is it's not an app. It is not an app. It is not owned by Apple. It is not owned by Google. It is a separate website. So there is no background data that goes anywhere, and it stays within the project. And the only background data we're using for this project currently is where are people filling out pads, where do we have gaps that we need to assist our counties, our 8 pilot counties, in helping them to fulfill that. But to be honest, in just our piloting it, 1 county in 2 months had already filled out 50 pads. And just in our beta testing alone, we had over 150 pads in 2 months filled out. So we have no doubt this is something that our counties are definitely excited about. So when we look at phase 2, it really is that learning community. It really is. We utilize BBI, the Burton Blatt Institute out of Syracuse University, who is in the forefront of disability rights in the nation. And they are doing our evaluation, so our quantitative and qualitative evaluation. In February, my team will roll out training to all crisis teams on the project. I already have over 200 staff signed up for the crisis team trainings in our 8 counties. My team, I have a law enforcement CIT trainer who is also working with all the law enforcement, and we will roll out their training based on as they're ready. As you know, law enforcement and hospitals are a little harder to engage, but they're very excited. Because as we know, this really helps. This may help law enforcement specifically enhance their jobs, reduce a call for service time, may decrease an officer-involved shooting because they have information at their ready, and also unnecessary incarcerations. And with that, I just want to show you our pad, our product. Whoops.
Advanced directive. My plan, my voice.
Can you hear it?
Proactively create a plan for a behavioral health crisis.
Yes, we hear it.
Getting started is easy. A pad can be created with a free account through the secure web-based platform, providing guidance along the way. The dashboard serves as a centralized hub for creating and managing pads. The first part, crisis directives, focuses on the crucial details that should be shared with professionals and others providing support during a crisis, like health history, communication preferences, and who to contact during a crisis. It also includes anyone who should not be notified. Completing each section encourages individuals and guides them to the next section. Treatment directives allows individuals to share supplemental information for professionals to consider when providing care, like instructions for medications, accommodations needed if receiving inpatient care, as well as any gender affirming and reproductive health considerations that professionals may need to factor into treatment. The PADS platform will be.
Whoa, what happened?
Psychiatric. Next section. Treatment directives allows individuals to share supplemental information for professionals to consider when providing care, like instructions for medications, accommodations needed if receiving inpatient care, as well as any gender affirming and reproductive health considerations that professionals may need to factor into treatment. The PADS platform will be available in multiple languages to ensure broader access for more communities. Once completed, it can be previewed as others will see it. Individuals can see what their PAD will look like when accessed by professionals and preferred contacts. They'll always have the ability to choose which professionals can access their PAD. The platform makes it easy to collect signatures needed to make it a legal document. It's as simple as reviewing the PAD, confirming who has access, and adding a signature in-app. As a professional, you will have the information you need to help inform decision-making, reduce liability, and enable a positive outcome for individuals like Richard. Research has shown that utilization of PADs can contribute to lower rates of recidivism in hospitals and jails. The PAD platform ensures key information about an individual's needs during a crisis is quickly accessible. Professionals can search for and find active PADs. The most important information is displayed at the top, and more details can be reviewed quickly below. You'll be able to see key information such as diagnoses, how to de-escalate, and how to communicate. PADs can be shared with an individual's preferred contact, who can provide support and advocacy on their behalf. The PADS platform helps individuals plan for behavioral health crises by voicing their treatment preferences, as well as empower advocates and professionals with information they need to offer more effective care and support. Psychiatric Advanced Directives, empowering and encouraging individuals to make decisions about their well-being. Learn more at padsca.org.
Well, what I tell you, I'm just clicking all over the place today. Well, my last slide said thank you. um, but one of the things I did want to most importantly bring up with all of you is that we are happy to have more counties on board this project. I don't know if any of you have read The Tipping Point by Malcolm Gladwell, but we do believe we are at the tipping point of changes in our behavioral health services, and we do believe that psychiatric advanced directives will make a difference. A conversation I'm having on a regular basis right now is with our Department of State Hospitals and the importance of having PADs and even peer navigators within the state hospital facilities. And why are folks not leaving the state hospitals and having PADs with them? Our ISTs are incompetent to stand trial, our 90-day in-reach. Psychiatric advanced directives, we truly believe, is a tipping point as we look at care of individuals with a behavioral health condition in California, but nationally. And I even on this project published a chapter in a book in France. That's how impactful this project is. So we do know that with some counties, there is MHSA innovation funding. This is a no-brainer project. It is a very simple process if you would like to be a part of it. If you use any other braided funding outside of innovations, you do not need the commission's approval. But right now, the approval is on consent. And so we just want to share this amazing project. Because again, we think that we are on the cusp of some major change. And with that, do you have any questions?
Hello, this is Al Sims, Director of Veteran Services for Solano County. And I probably have a question that a lot of people have. How do we participate? We're actually the neighboring county to both Alameda and Contra Costa. We're the poor rural neighbors, but we
Yeah.
would love to participate in this.
So ironically, do you know Deb DeMello? Deb.
Oh, Debbie, that name sounds familiar. Someone
Uh,
this at our last Behavioral Health Advisory Board. I wonder if that was Debbie.
Well, she is spearheading an effort in your county. She has been wanting to join for quite some time. It
Okay.
does, I mean, and I'm not going to lie, this isn't a free project, right? This does take a little bit of funding because we do have technology, we have peer support specialists, it is training, there is evaluation. So it's a very encompassing project, but if anybody wants to join, it literally, we are going through the county behavioral health departments. That is how we want to sign up in each county. So if your county behavioral health department, it is a simple appendix. It's 3 to 5 pages of why this is great for your county. You've done a presentation in your county, which I can come do. And then you do your 30-day, if you're using MHSA innovations, you go through all those hoops. If you're not, there are no hoops to jump through. You can join without all of that. The budget is run through our fiscal intermediary through Syracuse University. And so that's just, I mean, it is all the steps for replicability are really finally outlined now.
Great. Can you please put your email in the chat?
I was just going to say that.
Thank you so much. That is great.
Oh, oh, I've lost my, oh, there it is. Okay. And we have some other hands.
Hey, my name's Lori Monroe.
Sorry,
Am I
audio
muted?
was off. It's my
Oh,
phone.
okay.
Go ahead.
I'm from Butte County, and I'm a retired nurse practitioner. And so I'm really familiar with medical advanced directives and POLST. And they were developed before there was any kind of internet. And so a lot of it is still pencil and paper, which works well with a lot of people who need to fill them out. My question is, couldn't this just be implemented without all your fancy training if you had the just did the pencil and paper version that could still be scanned into clinic charts and hospital charts to be available in the emergency room? It wouldn't go out to law enforcement. I don't have a vision for how they have access to that kind of thing, but it would be something.
So I really appreciate that comment more than you know, because that is actually one of the biggest reasons why we created the digital version is because patient rights have been around for 30 years, PADs have been around for 30 years, and they're underutilized for the mere fact that to get the information in a PAD right now, it's about 30 pages. And it doesn't transfer with the person unless they've given it to their medical provider, which then becomes a HIPAA protected document and nobody else has access to it unless they've gone to the hospital or to their medical provider. So what we really are trying to investigate, and it is why the state asked us to do this, is how do we make it easier? So by the mere fact that we are, so you can, by filling it out digitally, it is then accessible regardless of what county you move to. So think about a population that also may move county to county. And if a person wanted the paper document, it can be downloaded as a PDF and they still can have a paper document. But instead of having to fill everything out pen and paper, we have a lot of click boxes where you literally can just click your answers and go through it so much quicker than having to you might forget. Honestly, when we created the platform, our peers said this is what we want because sometimes we forget this information. And the other aspect was, how do you help avoid someone from having to go to the hospital? And part of that is you want to address that crisis in the moment. You want to address it with a crisis team, or obviously, some counties, law enforcement is a priority call. And so, how do we have them help to de escalate that crisis so the individual doesn't have to go to the hospital? Thank you for that. Joe?
Hi, thank you so much. I clicked my video, but it didn't come on. But anyway, I am the chairman of the BHAP board for Mendocino County, and I am thrilled to hear about PADS because we just started working on our trust. And guess what? The attorney said, do you have an advanced care directive for the psychiatric aspect of things? And we like kind of deer in the headlights. So I think this is something that is overly needed. But the other question is, you mentioned that for a county to join in, there is a dollar amount. Do you have a ballpark or specific dollar amount that you wouldn't mind sharing? Because
You
I would
know,
like to take this to the county.
yes. So I will tell you what is average of what our counties have provided. So our frontier counties often have very little funding. And so they've provided anywhere from, and our project, by the way, has frontier, small, medium, and large. So the really amazing aspect of it is we have all aspects of the counties involved. So they have ranged between 25,000 and 79,000 for our frontier counties. Our small counties are usually, and that's for the project. So what they do for internal staff as well, that is on top of it. So our small counties usually are 200 and between 150 and 200,000 for our small counties. Our medium counties range about a half a million to a million. And then any large county is over a million. Some of our large counties had extra MHSA dollars. And so Fresno, for example, gave 3.3 million and Orange County gave 6.9 million. And so some counties that have additional MHSA dollars like the other aspect I want you to know is that it doesn't matter the size of your county, you get the full encompassing care and coordination and expertise from all the counties. So if a small county gives us 50,000, we still give them the full project. And that's partly why the large counties have given more so that smaller counties can give less, because obviously there is just less funding there. So that's about how it ranges right now.
So the funding for this project goes to the project and the people working on it at this time.
Correct.
Okay. And I would think at some point there would just be support going forward, and it would not, because those prices are pretty hefty.
So, well, there's 6 contractors, and this is my full-time job, believe it or not, and my team.
No,
Um,
I'm just
but
asking the questions
no,
because
and so we have to understand too is that the idea is I also work on legislation, and so we will be turning this over to the state of California. We will be working on legislation to make, okay, for example, right now our Secretary of State said we have a metal file cabinet for our registry. We're not going to update it. A metal file cabinet. Who uses it? Nobody. And so we obviously want to encourage, in a very strong word, of making our state Kentucky and North Dakota have digital PDF registries. We don't even have that. So we do want to change legislation and have this be utilized throughout the state of California. That, though, is going to be about 3 years down the road.
Thank you.
Okay, so we were waiting in the room. Let's go to the room first, and then we'll go to Ian.
Quick question. Is there now, or are there plans to build an interface with electronic health records, like with Epic or something like that, so somebody can go in and just push it out to their health record?
Do you know what that is? I love it. Yes, yes, yes. We would love to do, and that's actually part of what legislation would have to do, because that would fall in line with AB 133 and the interoperability or the data exchange. So there's 2 areas that we would like to create the connection. One is to law enforcement CLETS, which means dispatch would have access to it and it's protected. And so dispatch could get it if the person is given consent. And then through your EHR, yes, you could just push it. And that's the nice thing. Chorus, who's our innovator, would be able to create those connections. And I always liken it to an adjoining room, right? Chorus opens their platform and the EHR opens their platform. And otherwise, if a person doesn't give consent and the other platform opens, then at least the person didn't give consent. So yes, we would like, but we have to legislate that in order to make it, in order for that to move forward. But 100% yes. And a person can right now download their PDF and upload it into their chart. So that is, and so we are training our facilitators that if a person wants to update it to their behavioral health chart, that they can help assist them download that PDF and then upload it.
Thank you.
Okay, another in the room.
Hi, Allie Mink from San Bernardino County. I have a question. Do you have any data or research about the likelihood that once somebody puts together one of these pads that they will be used or followed? And the reason I ask is we actually had the old paper version, not a full pad, but a little yellow thing that you put, and it said name of the practitioner, medications, not to the extent of this, but what we found, unfortunately, was that when we physically handed it to somebody, so that's one of the limitations, of course, that it didn't get to the doctor, or that when we physically went to the location and asked to give the doctor the same information that we had, that many times they said, if this was working, then your loved one wouldn't be here. And so they chose, real story. So they saw the information, or they chose to ignore the information, saying that they were going to assess what the person needed. So that's my first question. And then I have a follow-up on that.
Okay. So part of it is training. That is what this portion of the project is. It is about training, and you cannot do a one and done. So we will be doing regular ongoing trainings with our crisis teams. But hospitals are out of compliance under 42 CFR if they are not asking. Also, they ask about an advanced healthcare directive, but per California statute, a psychiatric advanced directive is also a legal directive. Per federal code, all hospitals should be asking for a psychiatric advanced directive as well. Now, if you ask, I sat in a room with 55 doctors and asked how many of them knew about PADS, 4 of them raised their hands. It's education. And the thing is this is where I say we're kind of at that tipping point, because now technology is what is moving the world. And this technology, it'll be easy for them to access someone's PAD, get that information, again, based on consent. And so we really don't want to penalize them. We want to show them that here is a tool that will make your job so much easier. And by utilizing that individual's choices, and a directive is, if a person has lost capacity in the state of California, a directive must be followed. That's the law. And so if a person who has a mental health condition loses capacity, their directive must be followed. It's not a may be followed. It's a must be followed. And that is an educational aspect.
Yeah, so thank you for that. That's really important for information. The question I was going to ask about resistance from hospitals would be, is there liability / accountability if once they open one of these, they choose not to follow a directive for some reason?
You know what? Right now, under probate, it follows the same. Currently, under probate, it already protects the hospitals. It's no different. There's the same protection is still there that they have to do what's in the best interest of the individual. They need to utilize their directive, but if in their medical standard of practices, they have to make a different decision, they are not held liable. That is already in statute. When we go to legislation, though, we will want to make sure that we enforce that use and clarify that language so that we do protect the individual and protect, obviously, we want doctors to utilize it. We want law enforcement in the moment to utilize it if the person chooses that. But we also need to make sure that we protect rights, which is why we're piloting this, which is why I can't tell you, all our law enforcement, if anyone is here from Shasta County, your sheriff is amazing. Sat on a call with us for an hour and said, "Oh my gosh, I can't wait to do this. I can't wait for my teams to do this." And so I think folks are ready for these conversations. I think our hospitals are overwhelmed. And I think our beds are being taken up when we could potentially reduce that using someone's pad. And so I think a lot of this is going to have to be legislation and advocacy and training.
Thank you. Thank you very much. I love the idea. I'm sitting here just grinning. I think it's, I do a lot of work with peers, and I think that peer support specialists who have information about this can advocate for their clients to do this. And exactly that, there'll be a much bigger buy-in because they know, okay, I'm going to be in control or have some leverage, even if I'm not in a space where I can advocate for myself. So I love this.
Thank you. And we did find that in our beta testing already. Is that peer-to-peer, that is the most recent study out of France was that peer-to-peer in a state hospital, and we really mirrored that. Hands down, when I first started this project, only one county had peer support specialists on the project. All 8 counties now have peer support specialists. And clinicians can fill it out too. This is not at all, but it really helps to have a relationship, whatever it is, with that individual. And that lived experience really does help.
Okay, let's go to Ian.
Hi, can you hear me okay?
I
Yes.
can.
Okay, I want to say thank you very much to everyone. I'm a newly appointed member of the Berkeley Behavioral Health Commission, and I wanted to get some sort of a sense of the landscape. I have a background in municipal government. I did contract administration for the Operations Service Division of Massachusetts back in '94, helped build their online state purchasing website, and I'm now kind of filling in a whole lot of blanks. So forgive me for what's going to be like some real ignorance on some stuff. But my question is, you mentioned Alameda County is basically the newest of these. And I'm sitting here thinking about what an enormous gap this software rollout is going to address. And I used to do new product introduction and software rollout trainings for my previous company. And I'm sitting here like, okay, you have to train a bunch of first responders, fire, and the Berkeley Fire Department is going, when and who in Alameda County or how do I talk to anybody to sort of facilitate the link between the CAT team, response team, which I'm connected to, the Berkeley Mental Health Community Commission, et cetera, in general, all of these people that need to be signed up for this. I'm just sort of asking for that. And I'm sure I'll be able to follow up with just your email address, but I also really wanted to say thank you and just at least sort of practice raising my hand politely in these meetings again.
Well, if you reach out to me, I can send you the contact for Alameda County. Most of our counties are rolling it out as a pilot, with a small group, and then we're going to expand and expand and expand. We have another 3 years on this project. So we don't end this project till June of 2029, which is why if counties want to get on board, it is a great opportunity. It is a learning, as I said, this is the tipping point. We are learning information and we are changing and evolving as we go. And yes, AMR, fire often are the first ones out on a call. And so we absolutely want to train them. It would be great to have, the interesting aspect of it is as we get folks involved and they understand it. It makes so much sense. So
It seems really, yeah, thank you very much.
You're welcome. Well, if any of you want to reach out to me, you have my email. I obviously,
One more question.
oh, okay. I live and breathe this every day. My team and I do. And here I am 5 years into it, and I'm just as excited now as I was when I started.
Karen, I'm Maria Valencia with Santa Barbara County Behavioral Wellness. I'm wondering, you might have mentioned this, but where is all the money coming from? And is there enough money for all 58 counties if they were to join?
So ideally, we want the state to take this on. This should not fall on the burden of any of one county because this isn't just a behavioral health project, right? This impacts law enforcement. This impacts behavioral health, hospitals. This is a statewide project, right? The way we care for the individuals in our state doesn't fall just on behavioral health. The funding for this project came from MHSA Innovations. That's where the funding, all of it from phase 1 to phase 2, has all been MHSA Innovations. With Prop 1, counties that were going to join, obviously, a lot of them stopped because just the fear of not knowing what was going to happen with Prop 1. And as we know, large counties are having to cut $70 million worth of programming. It is very challenging. It's beyond challenging. I can't minimize that amount. And I came from a large county and I ran MHSA. I know how challenging this is. But as we look at legislating to the state, we want to turn this over to the state. And we basically we have some demands also. This should not fall on behavioral health. And if we can show in the next 2 years, 3 years, that look, we have reduced our calls for service, we have reduced law enforcement time, we have reduced hospital time, we have reduced ER stays, 3 days in an ER, that is cost savings. And so part of that cost savings, the state we can't just allow them to absorb it and use it someplace else, right? We want them to use that into understanding and utilizing this product and saying, hey, this makes sense. And so again, never in the whole projection of this project is it that ever any of the counties will be responsible for funding this at the end. We will want to turn it back to the state. No different than Cal Hope. It was a website that the state commissioned with Chorus Incorporated, and now Cal Mesa runs it and the state funds it. And peers can bill Medi-Cal. If the individual has Medi-Cal, you put a pad in their case plan, their master treatment plan, a peer can bill Medi-Cal. So again, we also are looking at sustainability, and part of that is sustainable. So, yeah.
Hi, Karen. This is Steve McNally. I love your presentation.
Hi, Steve.
It's a very complicated topic, but you just said bill Medi-Cal. You mean certified peers can bill Medi-Cal?
Yes.
So we have like 9,000 of them now.
Yes.
It would be helpful if we had a sense of context. I remember when we first started this that I could go to the Secretary of State with an advance directive,
Mm-hmm.
and it was online, and I could add something to it. Crisis, I'm wondering the crisis part and the non-crisis. The non-crisis part seems sort of similar to having a wrap plan that you can share with somebody else. I don't know what the differences are. We may not have time to go through it, and the other is just how many people, like we have 4,000 sworn officers in my county, just one county. We have 150 mobile response people. So I don't know what the 7 counties are. But my concern was always that, in a crisis situation, it can get overridden. And, but, it's going to be very interesting. We have a ton of money in it.
Yeah. Well, and if it wasn't for Orange County, this accessible digital technology wouldn't have happened. I mean, and so I am very proud that because you all put funding into this from Orange County, we did provide a beautiful, both user and professional version. So I am very proud of that aspect. I'm very proud of our counties for all coming together, because you know how one county is one county, and when you have 7 different voices, we still were able to move this forward very collaboratively. So, Steve, in your county alone, your crisis team is giving me 100. Right now, they have 124 staff, and they already have committed 100 of them to my training in February. So I already know that. And then your sheriff's office has a behavioral health bureau that will be training all of their officers. And so we do start small. We have the sheriffs of Shasta County, right? So that we're going to be able to do all of them. We have the sheriffs of Mariposa County, but we also have any of the other. We have police departments in our Tri-Cities area, Laverne, Claremont, and Pomona. So you have to start somewhere. And right now it's crisis teams and whichever law enforcement that we get, and we know law enforcement is going to take a little longer to roll out. Same with hospitals. But it doesn't stop you from having those conversations. I do believe by 3 years from now, we will have potentially tens of thousands of pads even already created, depending on the populations. But yeah, I mean, I look forward to giving you data in a year.
Okay. We've already taken a lot more time than I had anticipated. Do you have time for one more question, or do you need to go?
No, like I said, this is what I do.
All right, let's go ahead with one more question in the room.
Hi, Harold Walker, Federal County Behavioral Committee. Are the other directives required to complement this pad, or can you have the pad without all the other health directives?
Oh, you can have a pad without the other health directives, okay, which is why we are utilizing this project as the informational pad, because what we also encountered was many individuals, especially our TAPE population. If you think of that, and this is we are only doing 18 and older for a pad. But if you look at your 18 through 24, 25-year-olds, they don't even, my son's 27. He doesn't even think about, what do you mean I'm going to lose capacity someday? What do you mean I need to have an advanced healthcare directive? I'm 27. Whereas a psychiatric advanced directive is something that he can use now, and it transitions through his life, and he doesn't have to say, okay, mom, I'm giving you permission to have control over anything. It still gives him that autonomy. So you can, the interesting thing about all our directives in California, they're all standalone. So you can have one, you can have all three. And so it really is a preference at that point.